The decision took 1.2 seconds, not the typing, not the mailing, the decision itself. A medical director signed off on hundreds of claim denials in a single batch, each approved by his electronic signature in just over a second. He did not open the charts. He did not read the records. He did not, in any meaningful sense, review them. According to ProPublica, this was not a malfunction, it was the design. A system called PXDX flagged the claims. The doctor signed. The patient, somewhere, got a letter saying no. Here is how a claim is supposed to work. Your doctor recommends a treatment. A trained clinician at the insurer examines your specific situation and decides whether it meets the policy. That is the promise printed in your plan. The reality, in many large insurers, is different. The volume is too high for human review at the speed the business demands. So, software compares your claim against a list of procedure and diagnosis pairings. If the match fails the rule, the claim is rejected. No human looks at your case until you appeal. The PXDX system, reported by ProPublica in 2023, matched procedure codes against approved diagnosis codes. When the pairing failed the internal rule, the claim was bundled for denial. Over a 2-month period, the reporting found, the company's doctors rejected more than 300,000 requests for payment, averaging 1.2 seconds each. Many were routine. A blood test paired with a diagnosis the software did not list. A scan for a symptom outside the matrix. The patient had no way to know a piece of software, not a person had decided. Claim denial is not the only place algorithms decide care. In 2023, StatNews and others reported on a tool called NH-Predict, used by UnitedHealth subsidiary to estimate how long a patient should stay in post-acute care. The tool predicted the discharge date. Coverage was then cut to match it, sometimes against the treating physician's judgment. A 2023 class action alleged the company knew the model's error rate was high, that appeals overturned its denials roughly 90% of the time, yet kept using it because so few patients appealed. Consider what a 90% overturn rate means. When patients fought, the algorithm was wrong almost every time. A model that loses 9 challenges out of 10 is not a clinical tool. It is a filter. Its function is not accuracy, it is attrition. Most patients accept the denial. The few who appeal mostly win. The difference between those two groups is not who deserves care. It is who has the time, the energy, and the knowledge to push back against a letter. The legal defense for these systems rests on a technicality. A licensed physician does sign the denial. That signature, in theory, satisfies the requirement for medical review. Whether a 1.2-second signature on an unread chart counts as review is precisely what the lawsuits ask. Plaintiffs call it review in name only. The insurers say the systems flag cases for clinician judgment and that signatures reflect oversight. The courts are still sorting it out. While they do, the systems, in various forms, continue to run. The human cost lives in the gap between the denial and the reversal. A patient in post-acute care, told coverage, ends Friday, may be discharged before they can walk safely. A family, told the treatment is not covered, may delay it while they appeal. For some conditions, weeks matter. The algorithm does not see the patient. It sees a code, a date, a probability. The patient sees a bill, a closing door, and a clock they did not know was running. Regulators have started to respond. The Centers for Medicare and Medicaid Services issued a rule, effective for 2024, that Medicare Advantage plans cannot deny coverage based solely on an algorithm. A human must make a medically individualized determination. The rule is a line in the sand. It does not, by itself, undo the economics that made automated denial attractive. The volume is still there. The incentive to process it cheaply is still there. A rule changes what is permitted. It does not change what is profitable. So what protects you when software makes the decision? The same thing that always has, the appeal. When a claim is denied, demand the specific reason in writing, including the clinical criteria the decision relied on. Ask directly whether an automated system was involved and request the name of the reviewing physician. Then, file, and have your doctor's office write a letter of medical necessity. The denial was generated in seconds. Your appeal will take longer. That asymmetry is the point, and it is also the weakness. The doctor who signed in 1.2 seconds did nothing yet proven illegal in a final judgment. That is the disturbing part. A system can be efficient, signed, documented, and still treat your medical care as a line item to be cleared before lunch. The algorithm does not hate you. It does not know you exist. It was built to say no quickly and let the few who fight back take what they were always owed. The machine is fast. You will have to be patient. And you will have to be the one who does not throw the letter away. If this one stayed with you, Episode 8, on the 14 hours a week doctors spend getting permission to treat you, goes further down the same road. It is the human side of the machine you just met, the prior authorization grind that wears out the people trying to help you. It is on this channel.